Mark?
So hello, everybody, and thank you very much for being with us this afternoon. Today we have two well-recognized experts in thyroid cancers talking to us. From Houston, we have Mark Zaffirio. He's the head of endocrine surgery at MD Anderson. And from here in Dubai, we have Camilo Balpasha. Camilo Balpasha is a very good friend, and we've been working together for quite a bit of a long time. He's an excellent thyroid surgeon and head and neck surgeon. We're trying to see, Mark has not joined us yet, so we might get Dr. Carmelo to speak to us before. Second. Carmelo, please go ahead.
Oh, good afternoon, good evening, and good morning, ladies and gentlemen. As you know, we are connected with Houston. I think it's 8 o'clock in the morning there. It's 5 p.m. here in Dubai. It's a great pleasure to be here with Muaz, which is a great pleasure and great friends. Me and Muaz, as he said, we worked for many years together here in Dubai. Now I'm working at the King's College Hospital, London, here in Dubai, which is a new brand from King's College London, many of you know very well. I'm the pleasure to be with you and with Mark Zaffirio, which is well recognized as the neck surgeon, especially interested in thyroid cancer. We are waiting for Mark to be connected with us. In the meantime, just a few words. I know Muaz doesn't like to speak about him, but I must do it. He's a great surgeon with a fantastic predisposition to teaching. And this is the reason because we built this fantastic training center and ENT clinic in Dubai. And because he was working very close as a friend also with Professor Stamberger, and all of you know is considered the father of nasosinus surgery. And Muaz is considered the father of the otoscopic surgery. They build this fantastic project, and in a few weeks, Muaz will go to open this amazing clinic and training center. And my feeling is to share with you, with all the doctors who would like to train in the Gulf, in the MENA region. This is a fantastic opportunity. It's a gold standard clinic and training center that is doing.
Thank you, Carmelo. Thank you very much. Great having you here. I think what we'll do is that we will get you to give you a talk. So what we have to do is really exchange the seats. So I'm going to ask you to leave your microphone there, if you could leave your microphone there, and come here, and we'll start, Carmelo will start the talk. Thank you. Sorry, give me just 1 second.
The live.
Go ahead.
Is Mark connected?
Not yet. He's not connected. And we share the screen. And so if you want to go ahead and people.
Yes, sure. And welcome again. My presentation is very short. It's just to introduce the topic and Mark Zaffirio. And what the topic of today is advanced thyroid cancer, and what we are to go on. Sorry, move on. Okay, can we move this a bit far from my, or close it so I can see better?
can close it, but I'm waiting for Mark to
for Mark to be.
Yeah.
Okay. So the topic is advanced thyroid cancer. As many of you know, I know there are both doctors connected, but also some patients and some not doctors. So we try to make it more easier possible to understand for everyone. It's very well known that the thyroid cancer, the majority, 85–90%, are well differentiated thyroid cancer, which means are a very indolent behavior. They are more a chronic disease than a cancer, and fortunately, they are very easy to be treated with surgery and radiodiode ablation, because thyroid cancer is avid of iodine, so we are having these two tools to use. And 75–80% are originally from papillary, and 5–10% from follicular thyroid cancer. So for this kind of well-differentiated thyroid cancer, is not very difficult. Is in expert hands is a simple surgery, and with a good nuclear medicine available, the treatment is very good and the survival rate is huge. The problem is then 15–20% of this kind of well-differentiated thyroid cancer, unfortunately, they start or they can become radiodiode refractory, which means that we cannot use anymore the radioablation. And these are the percentage of cancer that unfortunately can spread not only local in the neck area, but also distant metastases, which the most common are lung and bone death. This is the main problem. So we include this 15–20% of radiodiode refractory in the, sorry, Moaz, to go next one.
Slide?
Yes, because
okay, just
yes, sorry. Okay, so the survival rate, as we said, is very good for papillary thyroid carcinoma and follicular thyroid carcinoma. I think is the only thyroid cancer of the body in which we can have more than 80% of survival rate after 40 years. Which is the top one for survival rate. Unfortunately, out of this, we are having also other differentiated cancer, which is the medullary thyroid carcinoma, which after 10 years, 65% survival means that unfortunately 35% of patients died for this disease. It is getting worse when we are facing with the poor differentiated thyroid carcinoma, and worse than worse, anaplastic thyroid cancer, and you can see then in 6 months, only 10% survive. So 90% of patients with anaplastic thyroid cancer, unfortunately, are going to die in about 6 months. This was the historical. Fortunately now, and Mark will show us all the results, fortunately we is changing the survival rate. So in the group of advanced thyroid cancer, now we include these radiodiode refractory, which are 15–20% of differentiated thyroid cancer, which they can start as presentation like this or became refractory in the future. The poor differentiated thyroid cancer, unfortunately, are only 35% of them. Another 2–3% are the anaplastic thyroid cancer. And unfortunately, also in medullary thyroid cancer, because we cannot use radiodiode, about 30% of them, although they are only 1–2% in total, but 30% of them became advanced disease with distant metastasis, very difficult to treat. Poor differentiated thyroid cancer usually grow very fast. For example, there is infiltration of the skin, local advance, so start immediately with presentation. So we are forced to do advanced surgery with more mutilation. And historical anaplastic thyroid cancer like this, for example, this is a lady who came, was sent to me by the radiotherapist after the treatment with the radiotherapy, to ask if there was anything to do for her quality of life in terms of surgery. Was an exophytic mass, was not infiltrating too much the thyroid. So at the beginning, I was tempted to do a massive debulking, including the thyroid, and put a large flap to reconstruct the neck just to give better quality of life. But of course, it's a palliative treatment. And surprisingly, after 2 months, the patient came back with these results, which is after 2 months of thyrokinase treatment, and which is an amazing results. And after 1 year, this is the results. And I'm sure then Mark will show us much more why this is happening, which kind of tools and which kind of
How did this happen?
treatment. This happened. This is one of our patients.
Was it just spontaneous? Like,
no, this was treated with tyrokinase inhibitors.
Oh.
And you will see now, Mark will discuss, I'm sure, about all of these new drugs that we are having, which 10 years ago was impossible to achieve this result, because as we said, these patients are going to die in 6 months, and now they can survive a few years with the medication. Advantage and disadvantage we'll see later. Mark is an excellent head and neck surgeon working at the MD Anderson in Texas, Houston. For who doesn't know, who is out of the States, or maybe there are patients who don't know what is the MD Anderson, is one of the most famous tertiary cancer center in the world. In the States, there are two, one in New York and one is the MD Anderson in Texas. He is also professor of the neck surgery department and the section of the endocrine surgery, associate medical director. Also with the MWADS, they are part of the board of the American Academy of Otolaryngologists. I had the pleasure to meet Mark in Taiwan 2 years ago at the Asian Pacific Thyroid Surgery meeting, where he did a fantastic presentation, and I'm curious to see the development of some patients with advanced metastasis in the body treated with the tyrokinase and then following eventually surgery. So, Mark, thank you very much to be here with us, and we are here to hear from you now.
Can you hear us, Mike?
Yes, I can hear you. Yeah, thank you. Wow, that was much too kind introduction, and it looks like you have a wonderful background there with the pool, and
yes, so but you don't know that we are having 40 degrees outside.
Oh yeah. Yeah, so good to see you again. Yeah, it's been I guess a few years since we've seen each other in Asia, and hopefully we will be able to see each other in person again soon. But that was a much too kind introduction, and I wanted to share my screen. Can I go ahead and do that now? Is that a good time to do it?
Sure.
Yeah. So let me see if you can see my screen. Can you see my screen now?
Yes.
So it was, I guess, a couple of months ago. I was very honored to present to this audience, and we had a very robust discussion about differentiated thyroid cancer and kind of the status of where we are and where we've come, over the last decade or so. And this talk will be a little bit more focused on the more dedifferentiated thyroid cancers. So the anaplastic, medullary, and biologically aggressive differentiated thyroid cancers, and specifically how we are currently thinking about the integration of systemic therapy with surgery for these patients. So I do have clinical trial research funding from Merck and Eli Lilly and Loxo. I don't receive any personal benefit from that other than just the funding for clinical trial research, but I disclose that. And so we mentioned we're going to be talking today about anaplastic, medullary, and advanced differentiated thyroid cancer. And so I think it's always good to start with a brief case presentation. We just saw a case presentation of a patient with anaplastic thyroid cancer who had an incredible outcome. It looked like. So we are seeing sort of new hope for anaplastic thyroid cancer in this sort of case, and sort of some of the principles and ideas that are presented herein hopefully will further illustrate that. So this was a 60-year-old gentleman who otherwise healthy, who came into clinic with a rapidly growing neck mass. You can see from his neck this very bulky sort of disease in his neck, and having some trouble swallowing, and he's having trouble breathing at night. So typical presentation for somebody presenting with aggressive thyroid cancer. So we did a biopsy, and it's anaplastic thyroid cancer, and he also has some papillary thyroid cancer in some of the lymph nodes. He doesn't have any distant metastasis, and he has importantly, he has the BRAF V600E mutation, and also a TP53 mutation, which you see the TP53 mutations commonly with even aggressive squamous cell carcinomas. So that is a sort of a non-specific mutation that you see with a lot of different aggressive cancers. So this is the actual CT scan. So if you look, his carotid artery is sort of encased in this tumor here, and here's the carotid artery on the left side, and he's got tumor inside of his laryngeal complex here. So, and if you look at the PET scan, this is what his PET scan looks like. So clearly a massive amount of disease in his neck. So how do we initially evaluate patients with these aggressive thyroid cancers, specifically anaplastic thyroid cancer in 2020? So the first thing that we, the first thing that we do for these patients is we do immediate rapid genetic molecular testing of their tumor for mutations, and specifically the most important of that being the BRAF V600E mutation, which we'll talk about a little bit more shortly. But there's three different ways to do that, that we are using. One is sort of the classic way. You do immunohistochemistry staining of the individual mutations. And you can do, this usually takes 3 or 4 days to come back. You can do, 1 or 2 or 10, whatever mutations that you are most interested in. You can do this from typically a cell block or a core biopsy. And so that's the first sort of way to do it. The next way is sort of this next generation sequencing idea. And so there's several platforms that for this. Some are from private industry like Foundation, where they test hundreds of genes which are commonly mutated in cancers. And then some institutions, for instance, MD Anderson has their own next generation sequencing platform that tests about 400 common mutations. And so that's another way. That usually takes a little bit longer to get the results. Usually you're looking at a week or two. So that's the disadvantage of that approach. And then we have a newer sort of approach, which we may have time to talk about later, but I think I may have some data about this, is the liquid biopsy, where we actually are sampling the patient's blood and looking for cell-free tumor DNA in the blood. And this only works for very aggressive cancers that actually shed tumor into the blood, and you can pick up the mutations just from a blood test. And that usually takes about a week to come back as well. And the advantage of that being that you don't need to actually even biopsy it. The disadvantage being that it only really works for the aggressive tumors like anaplastic thyroid cancer and other aggressive tumors where they shed tumor into the blood. The differentiated cancers, you're not gonna actually see the tumor in the blood to be able to do that type of testing. So when we look at anaplastic thyroid cancer, what's the mutational landscape look like? So about 40%, this is the bigger pie here, have what's called the BRAF V600E mutation, and we'll continue to talk about that shortly. Another 25% have some type of a RAS mutation, and then there's a spattering of other mutations, and then about 25% of patients don't have really any potentially targetable mutations. And so we're all familiar with the FDA approval of dabrafenib and trametinib, which is the BRAF-MEK inhibitor combination for anaplastic thyroid cancer in May of 2018. And this was a paper that was published. This was led by MD Anderson, published in the Journal of Clinical Oncology at that time. And it was a basket trial, and it was inclusive of a lot of different types of cancer, but anaplastic being the one type of cancer that showed the most dramatic response to these drugs. And so There were about 20 patients, 16 to 20 patients in this study. And this was actually the first trial and ultimately led to this FDA approval. And this was the first FDA approved drug for anaplastic thyroid cancer, and remains the only FDA approved drug for anaplastic thyroid cancer. There are, in the United States, there are several drugs which are FDA approved for differentiated thyroid cancer, those being sorafenib and lenvatinib. And then for medullary, cabozantinib and vandetanib. This combination was the first to be approved for anaplastic thyroid cancer. And so we can see here this dabrafenib trametinib combination works on the it's a BRAF and MEK inhibitor. There are other BRAF MEK inhibitor combinations that we use as well. Vimurafenib, cobimetinib being another. These are just made by different pharmaceutical companies. I think it's important to point out that it's always important also to look for the fusions. So for instance, RET fusions, you see those very commonly with, we see the RET mutation commonly with medullary cancers, but you do see a RET fusion about 1% of the time with anaplastic thyroid cancer, and as well as an NTRK fusion. And this is actually another FDA-approved drug, larotrectinib. It is not specifically FDA approved for anaplastic thyroid cancer, but it's an agnostic indication for any tumor that has this NTRK fusion. It is FDA approved. So, and these drugs do work pretty well for the few patients. Again, it's about 1% who have these fusions, RET, NTRK, or ALK fusions. There are targeted agents, and then for the RET fusions, we'll talk about these drugs a little bit later. We've seen remarkable progress with these drugs with medullary thyroid cancer. LOXO-292, which has recently been FDA approved for medullary thyroid cancer. It's also now known as Retevmo or selpercatinib. But again, it can be used for these for rare cancers that have poorly differentiated or anaplastic thyroid cancers that have a RET fusion. As was shown a few minutes ago, we can see very dramatic results with these BRAF MEK inhibitors with dabrafenib trametinib. And this was an example before treatment, and 5 weeks later, you see just a remarkable response of this gentleman with anaplastic thyroid cancer to this drug. And we have many examples of that, dozens and dozens. This was another patient who had 3 months of dabrafenib trametinib and pembrolizumab, which is immunotherapy, which we'll also talk about shortly, and a large FDG avid mass in the thyroid, and extending beyond the thyroid, actually, metastatic lymph nodes, and then complete metabolic response with just these drugs after 3 months. The PET scan is now completely negative. And so going back to our patient, he was treated for 4 weeks with dabrafenib trametinib. So this was the same gentleman shown earlier with the very bulky mass in his neck, and you see his neck looks a little bit more normal now. Also, his scan looks more normal. I mean, he still has this tumor in his thyroid, but it's a much different picture than what we saw earlier. But he does have this little nodule that's growing here, this supraclavicular nodule that's starting to grow a little bit. And so, this just shows that that these drugs don't work forever. And we'll talk a little bit more about this idea of resistance to or emergence of new mutations. And so this patient had emergence of an NRAS mutation. We actually biopsied this nodule, and at that point we added pembrolizumab, which is of course PD-1 inhibitor, and he stayed on this drug combination, dabrafenib trametinib and pembrolizumab, for an additional 8 weeks, and we'll talk about his outcome a little bit more. But going back to this idea of resistance, so if we look at, this was a paper that was presented at the American Society of Clinical Oncology. It's 2 years ago now, and hopefully we'll have it published by the end of this year. So BRAF inhibitors. So this is a group of patients with anaplastic thyroid cancer who have a BRAF mutation, BRAF V600E mutation. The top line is those that get the BRAF inhibitor. The bottom line is those that don't. And so obviously you see a dramatic difference in the survival here. Well, but if you look at the time frame of this, so you see the time here in years is only about 1 year. So we're looking at a very short time frame. And if you draw out these same curves to 2, 3, 4, 5 years, you'll see that that oftentimes the response drops off at about a year, so that you this benefit in survival may only last up to a year or so. So so this brings us back to our patient. We added the immunotherapy. So this curve that I showed here is only looking at the BRAF MEK inhibitor combination. So when we think about immunotherapy, again, this is a PD-1 pembrolizumab being an example of a PD-1 inhibitor. Other examples include atezolizumab, nivolumab, and then there are also the CTLA-4 inhibitors, ipilimumab, which is a little bit different mechanism, but immunotherapy certainly is on the radar for all types of cancer, especially aggressive cancers, and we'll look at a little bit of what we're seeing with anaplastic thyroid cancer with that. Just to remember that anaplastic thyroid cancer has a very hot immune microenvironment as compared to differentiated and medullary, which are less hot. When you specifically look at the this data was presented, it's been about 4 years ago now at the American Thyroid Association meeting. If you look specifically at those patients who have the BRAF V600E mutation, their PD-L1 scores are much higher in their percent positive cells than those who have the wild type, suggesting that these patients may respond better to immunotherapy. And so we go back to our patient, and after 13 weeks of dabrafenib, trametinib, and pembrolizumab, he has a remarkable response. Now he just has this sort of disease in his thyroid here, and you can see it's still going to be a little bit stuck to his carotid artery there. But if you look higher in his neck, where this was his airway was completely infiltrated at the level of the hyoid bone. With the images we showed earlier, now it's completely clear there. And if you look, the PET scan really shows it all. I mean, this is 13 weeks of dabrafenib, trametinib, and pembrolizumab, and pretty remarkable response there. He still does have some FDG avid disease in the neck, but it's a completely different scenario than 13 weeks previously. So now what do we do? And so given this idea that these patients will ultimately, most of them, if not all of them, develop resistance. So we need to think about what else can we do for these patients. And so about 3 years ago, we started integrating surgery into the sort of multidisciplinary treatment approach for these patients. So this was that we operated on this patient. These are particularly challenging surgeries. There's a lot of the reaction to the drug generates a significant inflammatory response, and that in turn, all that inflammatory response turns into fibrosis. And so we know from operating on radiated necks and things like that how it is to operate in fibrotic necks, and there is some degree of that with these surgeries. So they are a little bit challenging, but they can be done. And so this is we did a surgery. We removed the residual disease, including almost 100 lymph nodes, and some of those had anaplastic thyroid cancer. Some of them had papillary thyroid cancer in them. And you can see the pathology. This was his pre-treatment core biopsy showing these very ugly anaplastic thyroid cancer cells. And then in the residual tumor, you see all of this areas of fibrosis, these sort of pink areas here. And then you see these sort of nests of viable tumor cells in the specimen as well. And so we've now treated about almost 30 patients with this approach. We looked at our first 14 patients in terms of what the pathology looked like. And interestingly, after this BRAF MEK inhibitor combination plus or minus immunotherapy for anaplastic thyroid cancer, these are all BRAF mutated anaplastic thyroid cancers, 60% of them have no residual anaplastic thyroid cancer in the specimen. Now, we know that all BRAF V600E mutated anaplastic thyroid cancers essentially are derived from papillary cancers. So all of the patients have residual papillary cancer. So So they all have cancer in their specimen, in their surgical specimen, but 60% of them don't have any anaplastic cancer. It is just the papillary cancer that remains. And then 40% of them do have some residual viable anaplastic cancer. And most of the time it's a relatively smaller amount. A couple of patients had, 50% viability, but most of the time it's a small amount of ATC and a lot of more residual papillary cancer. And so this same first 14 patients we look at, this is a busy slide, and I'm not going to obviously go through these individually, but I just wanted to give a general idea of sort of how we're thinking about this in terms of, this is how, so these are, first of all, these are all stage 4B and 4C anaplastic thyroid cancers, meaning they're very advanced stage, and interestingly, a lot of them present with distant disease. So stage 4C in anaplastic thyroid cancer means distant disease. And so on their initial imaging features, many of these patients are unresectable. A lot of times that's because their carotid's encased or because it's extending to the prevertebral muscles, or the mediastinal vessels are encased, or they have significant laryngotracheal involvement, or such that, the surgery would be, a total laryngopharyngectomy or something, very obviously morbid for the patient, which, for a lot of these patients who have, for instance, stage 4C disease, distant disease, we would never normally do that. We wouldn't, subject them to a, laryngopharyngectomy in the setting of distant disease for something like anaplastic thyroid cancer, because we know that traditionally their lifespan has been very short. Well, so after we give the neoadjuvant therapy, we're able to reduce this disease to, where we're able to do more, not straightforward, I wouldn't say, still complicated surgery in many respects, given the fibrosis, but it's thyroidectomies, it's thyroid central compartment dissections, it's lateral neck dissections. We're not talking about doing, in general, although we have done a few more complex, tracheal resections and such with these cases, most of the time we're just doing thyroid central and lateral neck surgery. And so this is another example of a patient. I think this may be the same patient who goes, and I'll show a few other examples, who goes from unresectable disease here, carotid artery encase, to resectable after neoadjuvant therapy. And this is at the same level. This is the hyoid bone here, and this is the hyoid bone here. And so another patient who has 5 months of dabrafenib, trametinib, pembrolizumab for BRAF mutated anaplastic thyroid cancer. You see the carotid arteries encased here, all this disease in the neck. And after 5 months, we're looking at this, which is a completely different picture, and something that certainly surgery can be considered. Another example, so this is the PET scan, and this is the CT scan pre-therapy. This is a patient who's got tumor in the trachea, laryngotracheal involvement. So whereas after the treatment, this tumor has sort of melted away, so to speak, and now there's no longer frank tumor in the airway. And so initially, in our initial experience, we were, after surgery, and we did that with this first index patient, we were giving radiation therapy after the surgery in many of our cases. And so this particular patient, this was our index patient. Again, this was before there was any FDA approval for this drug. This has now been over 3.5 years out now. This patient who presented with massive disease in the neck, and he does remain on therapy. He remains on dabrafenib, trametinib, and pembrolizumab, and we will probably never take him off of that. But he's 3.5 years out now without any evidence of disease, which is quite remarkable. So we published this in Thyroid in last fall, our experience with our first 6 patients with this approach. Neoadjuvant therapy for BRAF mutated anaplastic thyroid cancer. And so we see the responses here: pre-treatment, post-treatment, pre-treatment, post-treatment. And then these patients all underwent surgery, and then the protocol is some of them get radiation, and then they go back on their drug regimen. And so our first 20 patients that we treated with this approach, again, we're up to almost 30 now, but our first 20, 11 of those patients were treated off clinical trial, and 9 of patients were treated on a clinical trial that is just finishing up now with the BRAF/MEK inhibitor, vemurafenib, cobimetinib, plus atezolizumab, which is a immunotherapy. About 55%, 11 out of 20 of those did receive postoperative chemoradiation after the surgery before going back on their drug. And so if we sort of look at their results, so those first 20 patients, what does that look like now? So first of all, their median follow-up is, this slide is is a little bit dated. So their median follow-up now is over a year and a half. So this is in this, it's 17 months here, but is now over 18 months. And our longest follow-up is now 42 months. And only 4 out of those 20 patients have died. And this is in the setting of patients, 60% of which presented with distant disease with anaplastic thyroid cancer, which is really unheard of, that you would have a situation where you haven't even reached a median overall survival in a cohort of patients with 60% of them having distant anaplastic thyroid cancer. And so we've also been able to maintain their local regional control. Only one of these patients has developed recurrent neck disease, and their functional status is actually pretty good. We had 3 patients who had temporary PEG tubes. Those were during radiation therapy that they needed that. And again, I told you about 55% of these first 20 patients received postoperative chemoradiation therapy. And then 3 patients had a permanent trach. Again, this was related to radiation therapy, surgery. These patients often have a vocal cord paralysis on the side of the cancer, but most of these temporary tracheostomies, most of these are temporary, although 3 patients did have a permanent tracheostomy too. This is a study that I have in press here, but is now actually is published. You can look it up on PubMed. It was actually published last week in JAMA Oncology. This is a study that we recently looked at. We looked at a broader experience of 470 patients with anaplastic thyroid cancer. This was a single institution experience over 20 years, and we took our patients from 2017 to present who were BRAF mutated, and looked at those who had neoadjuvant therapy followed by surgery versus those who had the BRAF/MEK inhibitor and no surgery. And really, this is not to say that this is a direct comparison between these groups, because obviously the surgery patients are a selected group of patients. These are sort of, it's comparing apples to oranges here, but just to show that how well these patients are doing, who are able to undergo the neoadjuvant BRAF/MEK inhibition followed by surgery. And again, our median survival in this cohort of patients is not even reached yet. It's definitely over a year and a half. And then if we looked at sort of a broader experience of how we're doing with anaplastic thyroid cancer, this is all comers, 478 patients over 20 years. And so these are patients who we broke them down according to some various sort of time periods: 2000 to 2013, 2014 to 2016, and 2017 to 2019. And we looked at their survival, and you see with each sort of time period, the survival is improving. And you see the most dramatic improvement in the 2017 to 2019 period, where now our 6-month survival rate is 80%. Our 1-year survival rate is 60%, and 2 years is 43%. And this continues to improve. So how did we get there? Well, a lot of this is the BRAF story. I mean, a lot of this is the BRAF/MEK inhibition and the dramatic and rapid responses that we see. And so when you look at that, you see the dramatic increase in targeted therapy, which includes the BRAF/MEK inhibitor therapy amongst these patients. who have presented in the last 3 years. 60% of them have received targeted therapy. And there's certainly going to be a survival difference in those patients who have the mutations and are able to receive targeted therapy versus those who do not. And this is looking at all 478 patients over that 20-year time period. And we do see a remarkable difference in the survival. And then we see that we're also increasingly using immunotherapy for these patients. So about half of our patients in the last three who presented in the last 3 years have received immunotherapy for anaplastic thyroid cancer. And finally, we are now operating on many more of these patients who were previously unresectable or not meaningfully resectable, and now after neoadjuvant therapy become resectable. And so we use the neoadjuvant therapy. We start with the systemic therapy for any patient. 95% of patients who present with anaplastic thyroid cancer are going to present with disease outside of the thyroid gland. It's almost unheard of or extremely rare that a patient will present with an anaplastic thyroid cancer that is confined to the thyroid, unless you happen to diagnose it postoperatively. It's just sort of an incidental finding, on the postoperative, which that's a different disease than somebody who is presenting with a massively growing neck mass. And so for those patients, they're almost all going to be 4B or 4C patients. And for the most part, their distant metastasis is going to drive their survival. And so you want to start with something systemic up front. And there are now very effective targeted therapies available for the BRAF mutated patients, which is 40% of the ATC population. And this will also help some unresectable tumors become resectable, and as we showed, and decrease the morbidity of surgery in these patients and their overall quality of life. You saw that few of these patients had PEG tubes and trach tubes, and this is in a population of patients who traditionally, within a couple of weeks, would have been trach and PEG dependent, if not dead. So it's a remarkable change here. So in terms of anaplastic thyroid cancer, these are the clinical trials that we currently have at MD Anderson for anaplastic thyroid cancer. We have an atezolizumab, vemurafenib, cobimetinib trial, which is immunotherapy, BRAF MEK inhibition, and this has enrolled 50 patients, and the results were just presented at ASCO last month. If we have time later, I can show those results. And then we have 2 upcoming clinical trials, which are going to be the pembrolizumab, dabrafenib, trametinib, followed by surgery for BRAF mutated patients. This is set to start in a couple of months, and then pembrolizumab and lenvatinib for BRAF wild type patients. And those, again, both will start in 2020. And so this was a slide that Mike Tuttle, I borrowed from Mike Tuttle, where he kind of shows that, the sort of RAI responsive tumors and how these patients live normal lifespans, and RAI refractory, as was showed in the earlier presentation, some of these patients end up dying of their disease. Well, the anaplastic, they almost all, immediately die. And so we've changed the landscape of that now. I do believe we're still not going to cure a large number of these patients, but some of them we will, I wouldn't say cure, but will remain disease-free up until the time of their death from, potentially other causes. And so, we've turned this disease into something that can be treated for years, and some of them, will not die of their disease, and then others will be able to live much longer and with a better quality of life than previously thought. So I wanted to just take a couple of minutes to look at the advanced papillary cancers. So these are not anaplastic cancers, and to look at how do these patients do with the BRAF inhibitor, because we actually know that the BRAF mutation is much more common in in papillary cancers than it is even in anaplastic cancers, because with anaplastic cancers, about half of those patients are follicular in origin. So they come from a follicular cancer, and those are typically RAS mutated anaplastic cancers, whereas the papillary origin anaplastic thyroid cancers are typically the BRAF mutated. But if you look at papillary cancers, maybe 60% of those are BRAF mutated, especially the advanced papillary cancers. And so how do those patients respond to BRAF inhibitors? Do they still have, these dramatic and remarkable responses? And so this was a study that I was involved in that was presented at the European Thyroid Association a couple of years ago, and will be published very soon, looking at 17 patients who were enrolled with intent to operate in a protocol for neoadjuvant BRAF inhibitor, which is vemurafenib, for BRAF mutated papillary thyroid cancer. And so when you look at these responses, so I guess the first thing to notice is that, so oftentimes when we're doing these clinical trials, we looked at this 30% response as sort of the threshold for sort of what we call a partial response. So only 3 of these 14 patients who, so we actually, 17 were enrolled, but 3 did not complete the 56 days. So we looked at 14 patients who had the vemurafenib neoadjuvantly for BRAF mutated papillary cancer, and only 3 of them had a partial response, over 30% response. So it is not anywhere near as dramatic as what we are seeing with anaplastic thyroid cancer. You see, other patients did have a response, 20%, 10%. So they do have some response typically, but it is not the dramatic response and the rapid response that we see with the more dedifferentiated anaplastic cancers. And then we ended up resecting 11 of these patients, most of whom we were able to ultimately obtain negative or microscopic margins. We did have a couple of patients who had some complications. It's unclear, to what extent the drug, having given the drug before surgery may have contributed. One patient who had actually a fatal hemorrhage a couple of weeks after surgery. This was a patient who had he had a previous surgery at another academic institution in the United States, and then he came to MD Anderson and had disease that was encasing his carotid and innominate artery. So we put him on this drug. It did shrink the tumor a little bit, 10 to 20%, but he had involvement of the wall of his innominate artery, and so we did a resection with vascular surgery, and he had a trach tube and a flap, but he unfortunately developed a tracheoinnominate fistula. And so to what extent the drug can contribute to these things, it's a little bit unclear. So what we have generally found, I guess, and I would just say in terms of general principles, is that for advanced differentiated thyroid cancer, non-anaplastic BRAF mutated papillary cancers, the responses are generally inversely proportional to the pretreatment growth rate. So if you've got a tumor that's behaving very poorly differentiated, like anaplastic, but pathologically it still looks differentiated, but it's growing very fast, it's very PET avid, those patients may respond. But the patients who are maybe they're aggressive, maybe they've actually even grown into the trachea or but it's been more of a slow process over time, those patients are very unlikely to respond to BRAF MEK inhibitor. And sort of generally modest response is the sort of the norm, or stable disease. And your extent of your surgery with that sort of 10 to 20% response, it doesn't usually change, whereas with our experience with anaplastic cancer is that it dramatically changes what your surgery would be. You go from a unresectable or a laryngotracheal resection to a thyroid neck dissection, which is typically not so much with the differentiated thyroid cancer. So, but it can be a very good strategy for patients with residual disease after an incomplete surgery, because you're looking for some reason not to operate on those patients who just had maybe they had a surgery and it was someone who wasn't experienced with thyroid surgery, and they did a sort of a peek and shriek where they kind of opened up and realized it was, maybe not resectable, and so they closed up. And, now what do you do? Well, you can, if they've got a BRAF mutation, you can put those patients on a BRAF inhibitor, let everything settle down for 6 months or a year, put off that surgery. And so those are patients who it makes a lot of sense. And then I wanted to briefly mention medullary cancer. And we have, I would just say that, so this is an example of a patient with local regionally advanced medullary thyroid cancer. So, he has, you can see he's got bulky lateral mectases. He's got a calcitonin, which is around 2,000. Another example of a patient, a 32-year-old bulky local regional disease, calcitonin around 20,000. So, this would suggest that this patient also has distant metastasis. Usually the calcitonin of 20,000 is not all due to local regional disease, and especially patients who have sort of mediastinal disease like this. So what do we do with these types of patients? Well, surgery has traditionally been the upfront thing to do for medullary thyroid cancer patients, unless they have, a significant amount of distant disease, which is progressive. But we do have FDA approved systemic agents also that we use. In these, as I mentioned before, vandetanib and cabozantinib, these were FDA approved back in 2011, 2012 for medullary thyroid cancer. These have been around for a while. But the issue with these drugs is that they induce, how they work is they work as VEGF inhibitors. So one of the ways that medullary thyroid cancer grows is by VEGF and VEGF receptor overexpression. And so these drugs have a significant inhibition of the VEGF component, much more so than other targeted therapy drugs. And so one of the issues with these drugs is that they can have a higher incidence of perforation, fistula, hemorrhage, tracheoesophageal fistula, or tracheocutaneous, or esophageal cutaneous fistulas. So using these drugs in combination with surgery can be a little bit of a challenge sometimes. And so when we look at sort of stepping back a minute, we look at sort of medullary thyroid cancer overall and sort of the mutational environment. And so I would say, I guess, first of all, we know that about 20% of medullary thyroid cancers are hereditary. And so we're not going to, those all have a RET mutation. But even for the somatic mutations, those that are or non-hereditary medullary cancers, almost half of those still have a RET mutation in the tumor. So, we're talking probably overall, if you take the hereditary plus the almost 50% of somatic, almost 50% of non-hereditary medullary thyroid cancers, that 60 to 70% of those are going to have a RET mutation because you're adding the hereditary plus those that are non-hereditary. And so, and those are usually the 918T mutation. And so we've seen, recently that LOXO-292, and this is a drug that, again, was just 2 months ago, was FDA approved for medullary thyroid cancer, for RET mutated medullary thyroid cancer, that is, and this is a RET specific inhibitor. The trade name is Retevmo, and it's also known as selpercatinib. It is now owned by Lilly. And so you see significant responses. So over 30% responses in the vast majority of patients here who receive this drug. And it's actually pretty well tolerated. I mean, you see hardly any grade 3 or 4, or 5 toxicities here, a few grade 1 and 2s, but these drugs are pretty well tolerated. And so we've started to consider, and we have a paper that is being looked at right now under review, studying this approach at neoadjuvant therapy for medullary thyroid cancer. And so just to present sort of one case, we don't have a lot of data. I'm going to show sort of the schema for a clinical trial we're doing along these lines. But, this is a 20-year-old who presented with a high calcitonin suggesting distant mets, and he did in fact have macroscopic disease in his spine, his lung, his liver. And so we look at his imaging, and his thyroid looks relatively unremarkable, but he's got very bulky lymph node disease. And so he's got this disease, which is, 180 encasing the subclavian artery. He's got significant mediastinal disease here, which is in the area where the left phrenic nerve and the recurrent laryngeal nerve would be. And so this would be a very challenging patient to operate on. And he's got a somatic RET mutation. As you can see here from the genetic testing, this is the RET mutation that he has. And so the first thing we did was we radiated his spine to sort of stabilize his spinal disease, and then treated him for almost 6 months on LOXO-292, the RET-specific inhibitor. And we did see about a 30% improvement in his visceral distant disease. And you see his tumor markers just drop dramatically from 16,000 to around 2,000 with this drug. This is the calcitonin plot here. And so, and this is something that we see commonly with these RET-specific inhibitors. You see, typically in calcitonin, you typically see like an 80% drop in their calcitonin, with and a little bit less of a drop in the CEA, probably an average of about 50% drop in the CEA. And so this is what happened structurally to this specific patient. So this was again the disease that was encasing the 180, encasing the subclavian artery here, kind of a little bit at the level of the sternum, which would have been not really a surgically resectable situation here. You can see the dramatic response of this tumor to the drug here, comparing these two pictures here. And we measured, this was about a 50%, a little over 50% resist response. You see, this is the aortic arch here, the little red star, and the tumors here have dramatically shrunk with this drug therapy. So we what do we do with a patient like this? So there's two basic options. We could leave them on the drug indefinitely. So this is a young guy; he's 20 years old, and certainly, the thought is he will probably be on treatment for the rest of his life, and hopefully that will be a long life, that he can perhaps live decades with this disease at this point. Given that he's got several drug therapy options, he's got the RET-specific inhibitors, but they're like any other drug. And we're starting to see this, although the data is not really out in terms of the clinical trials that are being done currently with these drugs, is there's some resistance to these drugs, as there are with any other drug. And so at the point that this patient develops drug resistance, he's then going to be, needing to be put on something like vandetanib or cabozantinib, which are the more dirtier drugs that are FDA approved, but they've got a lot of this VEGF receptor inhibition. And so those aren't as compatible with surgery. So do we sort of just leave him on the RET inhibitor indefinitely and just sort of until he starts to progress, and then sort of do surgery later? Because, oftentimes these patients do get in trouble with their local regional disease first. And so, if they start progressing down the road, even if the distant disease and the local regional disease are progressing, it's often the local regional disease that gets them into trouble first. Or do we decide, okay, we're just going to, now that we've gotten this significant tumor response, are we going to operate on this patient, get rid of the local regional disease completely, or at least down to microscopic disease, and then put them back on the drug, and so that ultimately, when they develop drug resistance down the road, that we don't have to worry as much about the local regional problem, and we're just sort of treating the distant disease at that point. And so that's what we decided to do for this patient. I mean, this is something that needs to be further studied in clinical trials, but we resected this tumor. I guess I don't have the pathology here, but similar to what we've seen, this is a completely different disease than anaplastic thyroid cancer, clearly. And so, the principle of seeing the response to the neoadjuvant therapy, pretty good response, 50% resist response with these RET specific inhibitor drugs. a lot of fibrosis with the surgery, so a little bit challenging, and you can see a lot. There were still a lot of nodes involved, but able to do the surgery, and he did very well from that. And so, if we look at where we are now, and I think I may have an updated slide that I can show later, but he was treated with Loxo, then he undergoes surgery, and now his calcitonin is the lowest it's ever been. And actually, I don't think I have it updated here, but it is now down to 200. And so he went from a calcitonin of 20,000 to 200 now, undergoing neoadjuvant therapy, surgery, and then back on the RET-specific inhibitor. And he's about almost 2 years out now. And so we are studying this in the context of a clinical trial now. And this trial is sponsored by Eli Lilly, who bought Loxo 292 or selpercatinib. This is a drug that is now FDA approved, looking at RET-altered thyroid cancer. So it's not only looking at medullaries, although probably 29 of the 30 patients will ultimately be medullary. I mean, but there may be a RET fusion in there that we can treat with this approach as well, RET fused anaplastic. We're looking at neoadjuvant therapy followed by surgery and sort of studying resist and quality of life endpoints and some tissue endpoints looking at resistance for this disease. So this is something I think that is certainly to be considered, although probably best under clinical trials at this point. So with that, I'm going to stop my sharing. I have and I'll open it up to any questions, and I have a couple of other slides I can show later if there's time. But I wanted to thank everyone for their attention and just to be able to share sort of this progress that we're making with these anaplastic and more dedifferentiated tumors in terms of integrating their systemic therapy with surgery and improvements in survival and quality of life. Thank you very much.
Mark, thank you very much. Excellent presentation, very comprehensive, and we can see how amazing these drugs and this trial are giving a fantastic prolonged survival rate to our patients. There are a few questions that are coming from the audience. Let me see. One is, what is your method of identifying the agents to be used in patients with BRAF 1600 versus patient taken up for immunotherapy? So I think the question is how you decide when to give immunotherapy in this patient.
Let me see. So the question is, are we talking about
identify the agents to be used in patients with BRAF 600, patient taken up for immunotherapy? Probably is I understand maybe you are using tyrokinase or.
So okay, let me look at this question. What is your method of identifying agents to be used in a patient with BRAF V600E mutation? I think the question is how do. It sounds like the question maybe, and if I'm getting the question wrong, please feel free to ask it in a different way or ask it again. But how do we identify which agents we're going to use in the BRAF mutated patients, including immunotherapy? Our standard of care right now is to all patients, and I do think that where it's available, this should be the standard of care. And I realize that these drugs are, probably, they're still relatively very expensive at this point. And so, in the United States at this point, we can get insurance to cover it because it's FDA approved. But like all drugs, I think that as time goes, the expense will drop as it becomes more widespread and more commonly used. But right now, the standard for most patients in the United States is any patient with the BRAF V600E mutated anaplastic should immediately go on the dabrafenib-trametinib combination, which is the BRAF MEK inhibitor combination that is FDA approved. So that's simply because that's the drug combination that is covered easily covered by insurance in our sort of health system because it's FDA approved. And so there are other drug combinations. There's vemurafenib, cobimetinib. And there's several others that can be used, but they're a little bit harder right now to get insurance approval. So we're studying, I mentioned the atezolizumab, vemurafenib, cobimetinib trial. We're studying other combinations under clinical trial, but it's difficult to always get insurance approval for those because they're not FDA approved. So right now, we're typically using the FDA approved dabrafenib, trametinib, BRAF MEK inhibitor combination. We are also starting all patients upfront on immunotherapy. And so we don't have, I can admit, we do not have excellent data for this in terms of like comparing just the dabrafenib, trametinib alone to the dabrafenib, trametinib, pembrolizumab. And so we are going to be studying that in an upcoming clinical trial. In terms of our retrospective data, we do see a difference. And so, that's why I showed the patient example where we added the pembrolizumab, and the patient had he was having an emergence of a RAS mutation. We added the pembrolizumab, and it basically shut that down. So we do think that it prolongs the time to response to the dabrafenib, trametinib using the immunotherapy. So using the triple drug combination. So we start all of our patient upfront on the triple regimen of dabrafenib, trametinib, and pembrolizumab, understanding that the FDA approval is only for the dabrafenib, trametinib at this point, but we are adding pembrolizumab, and generally we've been able to get the insurance companies to pay for that. Again, pembrolizumab being a PD-1 inhibitor type of immunotherapy, which is made by Merck. But there are other similar atezolizumab, made by Novartis and other combinations. So that can be used. So I think that's how I would answer that question.
There is another question, few questions from Federico Quarta. They are very interesting. You mentioned about some more difficult about the resection after neoadjuvant therapy. He asked if he's compared the difficult after radiotherapy, which is more, probably is the question.
Yeah. So it's not as difficult as a post-radiated neck. It's not as difficult as that. But it's somewhere between even if it's a virgin neck. So even if you're operating on a virgin neck, it's somewhere between a virgin neck and a radiated neck. I mean, there's quite a bit of fibrosis there. I mean, if we want to just say halfway in between, or maybe 60%, a little bit more toward the radiated neck, but it is not as typically as fibrosed as somebody who's been radiated.
Also asking if you see after the last neoadjuvant treatment that you need to wait a particular time, for example, for radiotherapy.
Yeah, actually we do not do that because we actually only hold the drug, the dabrafenib, we only hold it the day before surgery, because the thought is that these tumors are they're so rapidly progressive, and they have such a rapid growth rate, but they also have such a massive reduction in response rate. But if you take them off the drug, they will then start progressing, and so we do not want to leave them off the drug for very long at all before the surgery. And so we have typically, our practice now is we stop the dabrafenib the day before surgery. The trametinib, the dabrafenib being the BRAF inhibitor, I should clarify that. We stop the BRAF inhibitor, the dabrafenib, the day before surgery. The MEK inhibitor, we typically stop about 3 to 5 days before the surgery, because though that drug does have a little bit more anti-VEGF activity, and so it could theoretically interfere a little bit more with sort of surgical healing or bleeding or something, and so we typically stop that a couple of days before surgery. But it's certainly, we would not recommend stopping drugs for any longer before surgery than 3 to 5 days or something like that. And in our practice.
In this topic, can I ask one thing? I'm sure in your multidisciplinary team, when you are having these terrific, fantastic results, I'm sure the medical oncologists try to prolong the treatment. the surgeons try to push for the surgery. Do you have any experience of patient who refuse the surgery and carry on, and how long
Yeah, well, so that's sort of, I mean, the best that I can do in terms of, I can share my my screen again here shortly. The best that I can do in terms of the data on that is to show you this data that we presented at ASCO, that sort of
because just to remember the audience, we are talking always about unresectable disease. So when we face the patient with a terrific disease in her body, and then after 6 months, 1 year, wow, you are free of disease.
Yeah, so I would say this is a group of patients who, I'm sorry, this is, let me go to the slide.
So in summary, how long will the drugs will work? Because we know there is an escape.
Yeah, so the drugs typically will, the drugs typically will work. The median is about 1 year. They will work. So you know, this is the best I can do in terms of data on that. I mean, again, this is like comparing apples to oranges because you know, you can't really compare these, but this is a BRAF mutated cohort, all who underwent BRAF MEK inhibition. 20 got surgery, 43 did not. Some of these are because, you know, because they didn't have as good of responses. So obviously those patients are not going to do as well. Although I will say that 80% of patients have a very rapid and very dramatic response. But there are some other reasons why patients, you know, choose not to have surgery. But you see the patients who don't have surgery obviously don't do as well as the patients who have surgery. And so
we can say about 1 year.
Yeah, about 1 year. So this was the no surgery group. 50% were alive at 1 year. And you know, about 40% were alive at 2 years, 35, 40%. So that's sort of where we are with that.
Okay, thank you very much. We are having a few other questions. Which agency you use and how you use this change the treatment of these problem tumors? I think you discussed it.
Yeah, so yeah, we use the BRAF MEK inhibitors for all patients who have BRAF mutations. We also add immunotherapy up front for those patients. That's our standard treatment regimen now. If they're BRAF negative, which we didn't talk as much about that, BRAF wild type, which we have to remember is, you know, 50 to 60% of the patients with anaplastic. So that's not a trivial matter. We typically start those patients on lenvatinib and pembrolizumab, and that's something that we're going to be studying in a clinical trial coming up.
Okay, then is there any local regional recurrence reduction with LOXO?
Yeah, with the RET specific inhibitors, I would say we don't know. I mean, that's why we're doing the clinical trial. I think that our local regional control will be much better for patient. And again, the population is patients with advanced disease. So these are patients with local regionally advanced, and many of them, oftentimes, if you've got a local regionally advanced medullary, you typically also have distant disease, whether it be microscopic or macroscopic. So so that's the population you're talking about, and I do think for that population, that getting this initial significant, you know, again, I showed the patient who had a 50% resist response. That makes the surgery much easier, much more able to get a negative margin or, you know, microscopic, not leave any gross disease. So that's obviously, I think that's going to significantly decrease their local regional recurrence rate and improve their local regional control. But that's something that has not yet been sort of proven in any clinical trials as of yet.
Okay, then. Is indicated LOXO even the patient had the radiotherapy after surgery? I think the question if after radiotherapy and surgery.
Yeah, so yeah, certainly that patient could still get LOXO because the LOXO doesn't have, selpercatinib doesn't have a lot of anti-VEGF. So you know, one of the things that you start to worry about if you treat a patient with surgery and then radiation and it's an advanced thyroid tumor, I mean, oftentimes, you know, those are patients who, you know, you put them on a drug like lenvatinib, which has got a lot of anti-VEGF activity. They're going to be, over time, you're going to put them at a little bit of risk of bleeding or some type of, you know, tracheonominal or tracheocarotid fistula or something. And we haven't, I mean, LOXO is a relatively new drug, but but we don't have any reason to believe that that has any significant anti-VEGF activity where that would be a major risk as it is perhaps with some other drugs. So I think that would be relatively, of sort of systemic therapies, I think that would be relatively safer to use in that type of setting.
Then is right here, it's neoadjuvant. I don't know what exactly would like to ask. Then there is another question, which margin plus also what can get for radiotherapy. A question that I would like to ask about these things. Of course, when you do your treatment, the fantastic tyrokinase or inhibitors are working very well, and you're having this fantastic reduction. And you propose surgery. I'm sure that, again, in your multidisciplinary team, there is for sure
a yes.
between radiotherapists.
Yeah.
I would like to do radiotherapy. Why we should do surgery? Do only two treatment and not three. So how you are dealing this? Why you decide surgery instead of radiotherapy, for example?
Well, it's interesting. So just to step back, it's a great question. Step back for a minute. So, we started this approach about 3.5 years ago. That index patient I showed, who now is, alive and without disease 3.5 years later, that was our first patient for this approach. We published that, and we published since, further series. We have the JAMA Oncology paper that's came out last week. But when we started, we were seeing that, we were having these dramatic responses with BRAF/MEK inhibitors. But that if we didn't do something else, that they would have a response for a certain period of time, but then they would start to progress again. So, and then, you'd be back to square one, but except you wouldn't have the option of a BRAF/MEK inhibitor because they're already sort of resistant to that. So, and that would happen at, usually about a year. And we showed the data for that. And so that's, where we realized as a multidisciplinary team that we need to do something, because we don't have a good, we can use lenvatinib as a second line agent for patients with BRAF mutated tumors. But that also has limited effect in anaplastic thyroid cancer. So, there's limited options. And so we realized we need to do something before this disease starts progressing again, because if we wait for this to just start progressing again, it's a losing battle. Those patients are going to progress and they're going to die of their disease. And so we realized as a multidisciplinary group that we need to do something. And then, so then it's just a matter of surgery versus, radiation therapy, as you mentioned. And, I guess the bottom line is that these tumors are resectable typically after the neoadjuvant therapy. And so given that they're resectable and that we can do the surgery with maintaining a relatively good quality of life, as we showed, we felt as a multidisciplinary group, and our radiation oncologists are on board with this, that surgery is probably the best. In fact, as we originally started, oftentimes we were doing surgery plus radiation for these patients. So again, I mentioned of the first 20 patients that we did, 55% of those got post-op chemoradiation. So, it's basically trying to give them every chance that they have to control this disease. And so, I think, that was our initial standard of care, was the surgery plus the post-op radiation. And then we started omitting the radiation therapy for certain patients who both we felt good about the surgery plus, patients who have distant disease. It makes a lot less sense to sort of give radiation therapy, and because you're maximizing the local regional treatment and toxicity for those patients. You combine surgery plus radiation, and you're going to have a much higher toxicity profile than just surgery alone, especially in terms of their long-term swallowing and things like that. And so for patients that have distant disease, and even if you've completely shrunk the distant disease down to microscopic disease with the BRAF/MEK inhibitor and immunotherapy combination, we're not suggesting that disease is just gone forever. And so if they've had surgery, that's pretty good for their local regional control, and they're likely to get in trouble distantly at that point. And so rather than maximize their local regional treatment, for a lot of those patients who originally had presented with distant disease, even if they no longer have it, after the drugs, we now avoid radiation therapy for those patients. Whereas the patients who have 4B disease, where they had a massive tumor that was extending outside of the thyroid and no distant disease. Well, those patients, it makes sense to, no distant disease at presentation, at least not macroscopic. Those patients, you can say, well, we can cure these patients, so we can do surgery, then radiation, and maybe get a cure. And so it makes more sense to maximize the toxicity of those patients in terms of their local regional toxicity, even though, it does add a lot of toxicity to give the radiation after the surgery for those patients.
Okay. Mark, thank you very much. It was excellent to have you. It's a fantastic lecture. You are bringing so much knowledge and experience. I will leave no, it's okay. So I hope we can, maybe Muaz would like, my proposal to Muaz, if he agree, one a month, we can do a thyroid discussion about other topic about thyroid cancer, and maybe it will be one a month. What do you think, Muaz?
Yeah, absolutely.
We would love to do that. Yeah.
And
We could probably, we can also get a couple other members of our multidisciplinary team.
Exactly. So
that would be great to do. We would
expand a bit our colleagues and do one a month. A very nice discussion about thyroid cancer is a very hot topic. Yeah. Mark, thank you very much again. Enjoy your day, because it's morning and you're in Houston, so we are going to.
Yeah, you guys get to rest now. I have a whole day in front of me, unfortunately. So
we will have a dinner. Nice to meet you again.
Okay, be well. Take care. Good to see you again. Thank you so much.